Okay, welcome back everyone. We come to the session of the summaries of what we share the experience from multinational speakers, especially for the long COVID healthcare. Okay, I will summarize what I've learned in 3 days and we share for you. Due to we have a limited of time, so this summary is like the first day I do the summary. I will pick up the latest published journal for you to use as an evidence port, and you can search more and download using you can Google the names of the papers, the name of the authors, and you can download it. This kind of paper was picked up by my opinion only because I think it is interest, but all of you have experience in other ways, so it is better to share everything all together as a multidisciplinary. So multidisciplinary is the key for what we do in these 3 days. Okay, we will summarize that COVID-19 is different from the previous pandemic infection because before COVID-19, we know only the factors of the infectious triangle, host, viral, environment. But what we know now is the COVID. About COVID, it is a disease of abnormal immunity causes chronic inflammation. So COVID-19 is different from influenza. Influenza come, gone, we treat the patient, recover. But for COVID-19, most of the patients have the long-term sequelae. So this is the key factors of what we have to do now, because we will have millions of people to deal with the problem of long COVID. So we don't nearly win the COVID disease because the long COVID is like a long-term war. Okay, start from the concept of the disease. It is the immunology and immunopathology. What we know now, we know that some people may have severe disease, some people may have mild disease, and also few people around, I may not use the word few, around 1/3 of patients may have the post-COVID sequelae. This term will summary as a word PASC. You may have heard this word frequent in future, along with the word MIS in children, MISC in children. And I try to searching for the good summaries papers for the long COVID. We start with the paper from Mayo Clinic. In this paper, they summarize the pathophysiology and the organ specific. What is the effect of each organ obtained from the COVID infection, especially for lung? Some of the organ effect, we just found it because we have a study formerly we try to do the research and clinical trial to prevent COVID. Most of the resources was used to develop the vaccine, develop the antiviral, develop the acute treatment. So this year we have the Omicron wave, which is different. It's easy to spread but low severity. So we have time to study for the long-term side effect. Okay, and this is a summary of the remaining symptom along COVID. We have the studies at the month 7. Even the month 7, 1/3 of patients still have these persist abnormally. This affect the quality of life, productivity of work, which will impact our social, our nation, our GDP in future. And researchers always identify the key features, the 4 factors that may anticipate the long COVID patient. I give you the paper, the original paper of this summarization. The first, they focus on the pre-existing type 2 diabetes in the people with poor control type 2 diabetes. Type 2 diabetes always related to metabolic syndrome, obesity. So metabolic syndrome, obesity, plus the type 2 diabetes, all of this is the original of chronic inflammation. Chronic inflammation causes immunocompromise. The second, the SARS-CoV-2 RNA level in blood. It is easy to understand. If you have high viral load, you have severity of disease, but also you may have the long-term effect of the disease. So you have to eliminate the viral load from your body as soon as possible. This is why the WHO and US FDA, European FDA approved the pill, the antiviral pill, to use to delay or decrease the risk to develop severe COVID, like a Paxlovid, like a Molnupiravir. This kind of drug was designed to use within 5 days of infection. So the way of treatment for acute COVID, it will be like influenza 2009. If you notice, if you test positive, you should take antiviral as soon as possible. Like we can use the Tamiflu to control the influenza pandemic. And then the presence of some autoantibodies due to the COVID-19 causes like a mega inflammation. So this mega inflammation, or you call the cytokine storm, causes sometimes antibody. Because our immune system need to produce a lot of antibodies, sometimes these antibody may affect our tissue itself, and this may cause autoimmunity, and this causes the long inflammation after we clear the virus. And now we found that we found the report that some reactivation of the latent infection like EBV virus may play the role for the symptoms, for the development, for the risk of the long COVID. We have the paper to support this idea from China and from the Western country. We found that in the initial phase, in the people who already have the infection of the chronic viruses like EBV, like viral hepatitis B and C, this kind of virus may induce the further inflammation. It is like we can treat COVID, we can stop inflammation from COVID, but the effect of COVID infection kick up the sleeping EBV virus in your body. So we have a role of study of you to try to eliminate the Epstein-Barr virus in case of the test positive for Epstein-Barr virus, and we found that the long-term outcome, the marker of inflammation is decreased. This may be another approach to deal with the long COVID syndrome. We have more data on the Epstein-Barr virus detection in COVID-19 patients, and we have the data of the treatment. And for the this is another interesting long COVID summarization. This summarized in the form of chart. I like this. So please review this paper. And this paper summary about how to deal, what is the step. And they summarize the post-COVID syndrome categories by organ system. And we have the summaries for the primary care. I give you the primary care long COVID recommendation guideline from BMJ in the last session on Wednesday. Today I will give you more. This is interesting also. This paper not summary on the organic approach, but they adding the psychological approach and also the social factor. This is very interesting because we also know that socio-economical status, socio-economic problem also play the major role in the failure of COVID-19 control. Because we know as even in Thailand, sometimes for low-income people, they cannot do the social distance because they have many families members in one small home. So this point we have to concern also. And we talk about long COVID, what it is, okay, it is clear. We come to what we can do to deal with the long COVID problem. The first, we recommend the healthy lifestyle. We start from the exercise. I show you the paper that it summarizes the benefit of the lifestyle in long COVID. What kind of what kind of the exercise in long COVID you can read in the paper. We have clarified the potential benefit of exercise and what is the recommendation from for recover patient to return to exercise. Because one symptom of the long COVID syndrome, many patients complain the group of the PEM, post-exertional malaise. It is like you stay on bed but you feel like you running many kilometers. This is like a post-exertional, but in really you don't exert, you don't do any exercise. This feeling is the major complaint from the long COVID patient. So when we advise the recover patient to back to exercise, please advise the patient two things. The first, you have to start slow, you have to go slow. The second, you need more resting period. It is like you may exercise extremely every day with the resting only at night, and tomorrow you can repeat that exercise. But after you recover from COVID, you should extend or decrease the exercise day. It is like maybe exercise 3 days a week, and the 4th day is the rest day. And then if you feel okay, you can extend your exercise day to 4 days to 5 days per week. And this is another review, interesting review from Nature. In Nature, they summarize for the mechanism, for the timeline of what virus do in our bodies. You see, the magic number usually roughly allows around 6 months. If you see the paper, many papers, we know that many patients, 1/3 of patients still have symptoms at 3 months. I review many papers. It said that at the 3 months in the patient who have severe disease, more than half of patients have a long COVID syndrome. So in future, maybe next year, next 2 years, the definition may extend to 6 months, especially for the COVID situation, to define the chronic fatigue syndrome or long COVID. And the summary is the post-COVID in by organ system. And one thing we need to understand that this is a new kind of the health problem. So we do need multidisciplinary approach, not by physician only, not by alternative treatment only, not by conventional, but we need to all of the stakeholders in the healthcare sector have to do everything together to find the best way to fight the long COVID. So come back to the lifestyle. Lifestyle adjustment, especially the role of nutrition. We have the data that is clear, like a plant-based diet, plant-based protein. And then we have the term recovery-focused nutritional therapy. The keyword is the nutrition or diet pattern that low inflammation. This is the key. And we also found that in the patient who have underlying malnutrition, the recover is not come to the full recover. This means that increase the proportion of the long COVID syndrome. And the key is the malnutrition. You can study more in this slide. Sometimes we may need to ask help. Doctor, we may need to ask help from other healthcare worker like nutritionists, like the rehabilitation doctors to do the thing together. Because usually doctor may lost their time to treat the acute problem of the patients, a lot of patients with COVID. But after we can help our patient from the crisis, this is time of recovery. So nutritionists play the major role in this period. And this is the sample of multimodal nutrition therapy. You may see some kind of the target nutrient like vitamin D, because we got the data from the past 3 days that vitamin D have an impact on immunity. And the protein and omega-3 fatty acid. Omega-3 fatty acid help promote immunity with the clear evidence from the cancer patient. We found that the omega fatty acid from olive, from fish oil is the immunonutrition. But if the patient need a lot of active immunonutrition, they may not obtain from from everyday food. So functional food and supplement can help. This is why we talk about the supplement and functional foods in this conference. This is the diagram of how to deal from acute to subacute, early recover, and the long-term recovery. When we talk about the healthy diet, for me, if some of you have a chance to attend my presentation, nearly all my presentation, I always to pick up the UK government Eat Well Guide. It is like the อาหารหลัก5หมู่ in Thailand. This Eat Well Guide you can download from the government.uk website. This is the recommendation. This is the updated of what we should eat. This is in the moderate way. It is a eat well. But if you have the disease, if you have health problem, you may need to change some component in this. I will focus in 2 things. You can read this on the slide. The first, the role of the carbohydrate and the role of the protein. Okay, the protein should be, it is better to be plant-based. It is better to cooking that kind of protein on the low inflammation. It is like you should avoid sausage. You should avoid the food with preservative. You should avoid grill or direct heat. It is better to cook in a different way. And for carbohydrate, the first step, please select the whole grain. Please select the high fiber, and then control the amount of carbohydrate and control the quality of carbohydrate. I mean that you should pick up the glycemic index. The glycemic index will tell us what is the rate of your body's of the blood sugar level in your body to elevate after you take some kind of carbohydrate. Okay, I will show you the picture in the slide. Okay, low GI carb is better for post-COVID. Okay, because you see in the low GI it mean that when you take this kind of food, your blood sugar rise up slowly. This is like whole grain, like high fiber sugar, high fiber bread. But compared to like a sweet, like a high fructose syrup, this is high GI. High GI causes many inflammation and many bad effect to our organ. I will go back to slide of the hydration. This is important. Please drink adequate water, adequate hydration. It is need. Okay, this is the kind of pictures of anti-inflammatory diet. Why we have to talk about the diet? Because diet drive everything in our body. You are what you eat. What you eat go to your GI tract. Your GI tract have to digest and absorb. COVID-19 act directly to damage your GI tract and make them malfunction. So during the recovery period, you should adjust your nutrition to help your GI tract. Okay, and not also the effect on the GI. GI also affect the lung. We have the word gut lung axis and gut liver axis. So this kind of abnormal in one essential organ like GI, like intestine, may affect to other vital organ like lung, like liver. And we also found the many clinical data about the role of the probiotic in the preventive and in the treatment for COVID-19. Because we know COVID-19 is about the inflammation from the abnormal function of our immunity. Probiotic can rebalance and can some people may have the chronic inflammation from the dysbiosis. The dysbiosis is the abnormal in the proportion of good and bad bacteria in your colon. So this process of the dysbiosis causes inflammation in colon. You may have heard the word the leaky gut. This kind of the colon inflammation induce systemic inflammation in our body. Systemic inflammation in our body causes the hyperimmunity when you have the COVID infection. So you should balance your gut microbiome. If you can test, I recommend to test because you can adjust what kind of the probiotic, bacteria, fungus, what is the major species should be at. And if you have the like a fungus like a candida overgrowth, you may need to take some antifungal to clear this overgrowth first, and then apply the good probiotic and prebiotic. Okay, this is an example of the data of the gut microbiome and COVID-19. When we talk about the long COVID, I summary about the long COVID, but I forgot to talk about what is the long, you know what is the long COVID, but what is the amount of the long COVID? Can we count, can we measure? Because as a doctor, we know we have to believe in objective, that more objective than the subjective, because for subjective symptom, you can measure. But for objective symptom, you can measure, you can measure and you can compare before treatment and after treatment. In the international level, we use the fatigue scale because you may know that the word chronic fatigue syndrome turned to long COVID. For chronic fatigue syndrome, we have the international calibrated score called CFQ-11. So please find the CFQ-11. For Thai doctor, you can search for this CFQ-11 in Thai language because this kind of the score we use in the occupational medicine to measure the chronic fatigue syndrome of the worker in the factory, and they find a way to deal with the problem. We may apply this kind of the questionnaire score to apply to our patient. So we should categorize our patient by the like a standard yardstick. So the Shatler fatigue scale is okay, and it is many calibration paper published. The first I show you some paper. We have the paper that use this kind of score to search for the prevalence of the fatigue, because when you have score, you can use the same score to every people. You can calibrate. You can tell in the score, because for people by people, if it is a subjective, you cannot compare. And then they have tried to treat the patient or try to manipulate the chronic fatigue syndrome, starting by measure the score and apply the intervention. This intervention is the systemic enzyme and probiotic supplement and measure the quality of life score. You will see the result in this chart. There is improvement in the fatigue score, but due to this is a very early clinical trial and very few sample size, but this kind of paper paved the way for us to repeat the kind of study It is like if you want to study the role of enzyme inflammation or supplement chelation in Thailand, you should start with the standard score first and then apply the control group, experiment group, and then measure the result. So when we have published the paper like this more and more, we can summarize what is the recommend process, what is the recommend supplement, what is the recommend approach to deal with the chronic fatigue syndrome or the long COVID. And in Thailand, we have the standard enzyme and probiotics. The Texime probiotic, even it is labeled probiotic, I have to use the word symbiotic because it gives us the prebiotic in form of Jerusalem artichoke and the lactoferrin. And for the enzyme, I recommend to use two group of enzyme. By my experience, the first we add the digest in nearly every big meal of the COVID-19 patient because it helps restore the function of digestion. If we improve the digestion, we have the better absorption. And then protease or nattokinase or NKCP will help you clear like a debris, like the debris of the inflammation remnants in your blood circulation. So combined together, it will make your immunity restoration. And when add the probiotic, for by my experience, I recommend my patient to take the probiotic 2 tablets at night. Probiotic of the Texam come in form of capsule. You can swallow whole capsule because many probiotic in Thailand it come in form of the powder or sachet. Some people don't like the taste of of that powder, and someone afraid that can it be involved by the gastric acid. So for the special formula capsule is it can confirm us that the probiotic was delivered to the colon. This will be the slide of the summary, the summary slide. The long COVID-19, I have to use the word the long COVID 22 and maybe 23, 24. If we are lucky, it should be 20, 29, the maximum. I don't want to talk about this kind of disease in the 2030. So the key is the improper individual immune inflamed inside. It is improper. And the characters, the effect is individual, different people by people. The underlying immunocompromise causes the high viral load. High viral load has the severe disease. And then the cytokine storm comes. Cytokine storm causes a mega inflammation and lead to secondary immunosenescence, because sometimes when our immunity was driven to release a lot of antibody, like your B cell, when your B cell was stimulated to release a lot of antibody, or T cell was stimulated to divide more and more and more, they exhaust, they lost the resources to build, to divide, to create the new active T cell. So in this situation, we may call the immunosenescence will causes many disease after and the damage in many organs that causes the long COVID syndrome. For this year, immunosenescence is very interesting point of the research. This is the biological defect in the number and function of immune system. In the number mean that some people have the leukopenia. Function mean that if we check like immune activity, we found that the activity of the immune cell like NK cell is dropped. If you have a lot of numbers of immune cell, but it is inactive, it is meaningless. So we have to measure, we have to know, we have to test, and then we'll find a way to make it better. This kind of defect caused by COVID-19 may be recovery or preventable. This is the key. This is why we have this conference. We want to recover. We want all of you to use the knowledge in these 3 days to make the patient recover. and it is better to prevent the other people from infection and prevent other people to have the long COVID syndrome by proper management, especially low inflammation lifestyle in any way. We have to start from non-pharmacological, the lifestyle change, low inflammation diet, exercise, adequate exercise, and mindful living. When we treat the patient, we have to think about body and mind and make everything better together. But for the pharmacological, not yet established pathophysiology of the COVID-19. You may have heard I talk many times about the immuno, but it cannot answer all the question. I think we need some jigsaw to fit in and link the possible pathway together. Like I talk about the Epstein-Barr virus, in future we may have more study on the carrier status of the HBV virus or other virus that is the less that was ignored, but it will be repeat the research during the long COVID crisis. And then we know the systemic infection and immune dysfunction are the key, but there is no positive clinical trial report the use of the systemic steroid. This is very important. Systemic steroid play the major role in the acute treatment, but not the long COVID status, including NSAID, except used for symptomatic. If you feel malaise, if you feel pain, you can use the NSAID, but you have to aware of the NSAID side effect. But you cannot use NSAID or ever corticosteroid, dexamethasone, prednisolone in long term to control the inflammation because COVID-19 or long COVID is different from autoimmune disease. Other autoimmune disease like the rheumatoid arthritis, like the SLE, it is different. So the prevention is the first priority. Practical social distance, vaccination. Vaccination still have benefit. The first, to prevent death. The second, it may decrease the chance to develop the high risk, the high severity, especially the high risk group. You can check the high risk group in the webpage of WHO. It is like the old age people with underlying medical disease that causes immunocompromise, and keep healthy lifestyle. Then the pharmacological experiment. Most of this kind of experiment we call the drug repurposing. We use the other approved indication drug to fit in with the pathophysiological effect of the COVID-19. Like we use the anti-inflammation effect of ivermectin, anti-malaria that have the report of success in other autoimmune disease. And we may use the concept of combined antiviral cocktail in HIV. We may use the convalescent plasma from the recovery people for the recovery patient who donate their plasma to inject to the new infection people and many. And now we have the game changer, the novel antiviral pill and shot. This kind of approach, it is like, okay, if you cannot control, you cannot close, you cannot lock down your city, you have to let people free do their job, free of working and living. But you need to test. If someone tests positive, what will we do? We give them very early the drug to control the viral replication, the early antiviral approach, like we early prescribe Tamiflu if we know any people have the influenza. Now we have the pill that is very easy to use, the Paxlovid and the Molnupiravir. Paxlovid and Molnupiravir have the different indication to use. Molnupiravir we will use with the old people who have a lot of the drug to treat underlying disease because Molnupiravir have lower drug interaction, but it is teratogenic. Molnupiravir cannot use in the pregnant women and little children. While Paxlovid, it has the less the side effect in teratogenic, but it has a lot of the drug interaction. Paxlovid is the kind of the antiviral cocktails. It combines two things. It combines nirmatrelvir antiviral plus the boosted ritonavir. This is the idea of HIV. We use the boosted many antiviral anti-HIV drug and boosted with ritonavir. Ritonavir in the Paxlovid used as a booster. And we also have the shot, the kind of the monoclonal antibody that inject when you infect the COVID, and it decrease the chance to develop the severe disease or hospitalization. So you may find that a lot of the approach we use today, because there is no well-established data, but you have to use the objective approach. You should identify what is like a KPI for your practice, for your treatment. It is like, if you can measure, you can test, please do the test. And you should follow up and do the test after you apply any intervention. And it should be multidisciplinary. Sometimes the treatment may come from non-medical side, like from we may got some kind of innovation from out of medicine arena. Many medical equipment sometimes they came from other industry. And conventional treatment need to be combined to complementary and alternative medicine. So we have to focus on inflammation and immune dysfunction by functional food, supplements, enzyme, and the symbiotic. And also chelation may help to remove the toxic molecule from your blood circulation and decrease the inflammation level. But what we do, we have to base on the clinical evidence and close follow-up. We have to control underlying disease also and check the reactivation of some infection. And most of all, treat body and mind, and always empathize individual, patient different people by people. So it is our job to empathize them and individualize our intervention, our treatment, because some treatment may be fit for some people, while some people may not need some kind of treatment or may need more treatment. And in the next year, next 2 years, I think we will have the interest research to talk about it. So for this day, thank you for everyone to join our session. And I will close for the presentation and start for the session of question and answer.
Thank you, Doctor. Thank you so much for your summary. You have been very helpful, and the information has been very, very educational and encouraging. So right now we are going to proceed for our question and answer. Dr. Milton is still available right now for Q&A. So if you do have any questions from the floor, please feel free to ask your questions. You can actually type it in the chat box. Dr. Jirached would also be around to also take your questions if you have any.
Yes.
Both of these doctors have the wealth of experience and information. It's marvelous that they have taken time to share with us.
If the audience have no question now but have question after review my slide and other speaker slide, you can use our social media channel to connect to Taiwan and send the question. Yesterday, I got a very interesting question from the audience, and I answered back in the line. So if all of you have like a suggestion, not only question but suggestion, we also need suggestion, because all of you, I think you all Thai doctor, even Thai people, we have the experience to living with COVID, different people by people. So we may share the experience. Sometimes due to when we have no standard guideline, we have to apply the other's experience of the response, what doing well, what should not do all together. มีคำถามจากทางฟลอร์ไหมครับ โอเค Okay, the question from myself to Dr. B. What is the recommendation of the enzyme supplement for practical? If we can, due to many Thai people, they aware of the pill burden. If we can pick up only two kind of the textile product you recommend, what is the your top pick two things?
Okay, well, first of all, I'd like to say hello, Dr.Jirached. I remember you from when I went to Singapore,
Yes.
and you look younger now than you did back then. I don't know how you do it. Okay, so I use a lot of the proteolytic enzyme blend because of the many immune supporting benefits it has. I am able to use those proteases with anything that walks through my door because, again, inflammation is a common denominator in whatever the name of the disease brings. It's just an inflammatory response at the cellular level that expresses into a disease name. So the proteases are most definitely the product I use the most, and I can use them with sports related injuries. I can use them with systemic conditions, with my cardiovascular presentations, diabetics, high blood pressure, and just the gamut is very broad. So definitely a probiotic, knowing that most diseases begin in the gastrointestinal tract. I also use a lot of the digest, because if we're able to clean the patient's diet to more organic, natural, whole food, plant-based, and we're able to have them digest those nutrients completely, we can restore that gut function. And along with the proteolytic enzymes, we can quench inflammation. So those are my two most prescribed products from Texime.
Okay, and how to use it? Like, what is the best time to take protease? What is the best time to take the digest, with meal or without meal, or how many minutes after or before meal?
Correct. So enzymes, it depends on what you are trying to accomplish. For example, I have a patient eat a meal and I have them take a digestive formula, which Texime has digest, that has the lipases, carbohydrates, and proteases in order for that patient to digest everything that's on the plate. So those are definitely with meals, and the amount varies from patient to patient. I hear you say that in your approach to treating patients, it has to be individualized. Well,
Yes.
Enzymes are also the same. There's not one shoe fits all. Some people may need 2 to 3 capsules. Others may need just 1 capsule. But the more and more you use enzymes, you get to have a sense of how many capsules work for that individual. So I always recommend to my patients to play around with the amount of capsules until they're able to eat and digest and not have fullness for a prolonged period of time, not have gas and bloating. When they reach that point, then they'll know how many capsules they need per meal. The proteolytic enzyme blend, I recommend those be used on an empty stomach. Why? If you take them with meal, the proteolytic enzyme will start acting on the proteins in the meal. So if you want it to reach the circulation to be more of a systemic support, then you take them with an empty stomach so that it has nothing to digest. It has no proteins to digest in the gastrointestinal tract. It will be absorbed intact into the circulation and thereby impart their function in the circulation. So the proteolytic blend on an empty stomach, and also it depends on the clinical presentation of the patient. If I have a patient, for example, that has a sprain of the ankle through a sports-related injury, and it's a grade 2, grade 3 ankle sprain, I have them take high doses of the proteolytic enzymes on an empty stomach. I have them take up to 4, 5, or 6 capsules 3 to 4 times a day. The beauty about these enzymes, doctor, as you know, is that there is no toxicity involved. Your body uses them the amount it needs, and whatever it doesn't use, it either recycles them or eliminates them. So there's no overaccumulation of these enzymes in the tissues like certain drugs on the market. So there is no overdosing. You will always use it. The body will always use it for what it needs. And if it doesn't need them anymore, like I said, it'll either get rid of them, eliminate them, or recycle them to be used for something else. So don't be afraid of high dose proteases. As a matter of fact, the Baylor study that I showed, which decreased pro-inflammatory cytokines, they used 5 grams of the proteolytic blend in these students. 5 grams equates to about 12 capsules a day. So they used about 4 capsules 3 times a day on that Baylor study. So I tell my patients, don't be afraid. There's no overdosing on it. There's no hepatotoxicity. It's not tetragenic. It will get used or eliminated. And it has a half-life of about 3 to 4 hours. So it doesn't overaccumulate in your body.
Yes, thank you. We have to be noticed that enzyme is not a chemical drug, so enzyme itself didn't join the chemical reaction. It acts as an enzyme like a catalyst to the chemical reaction. So it is different from drug. And for the report data of the toxicity, around 30 years ago, when we have no kind of the good chemotherapy and targeted therapy like this day, we have the concept of cancer treatment called the Gonzalez therapy, the Gonzalez regimen. You can search in the website of the NIH of USA about the Gonzalez regimen. In that time, the Gonzalez regimen used a very surprising amount of enzyme. We have report some kind of response, but not wonderful like the chemotherapy, like the targeted therapy. But the interesting, very rare report side effect. Very rare reported the serious side effect compared to some oral chemotherapy, which was claimed the softest chemotherapy. They have common side effects like white blood cell suppression, leukopenia, than the enzyme. So for the COVID, for the long COVID, for the chronic fatigue syndrome, we have to deal with inflammation. So corticosteroid, systemic steroid, long-term NSAID is not the answer. Please think about when you treat the rheumatoid arthritis. If you can remember that your teacher always said that rheumatoid arthritis needs short course steroid, but you need the DMARD, disease modify. So you need the kind of the substance to modify your disease. And when you cannot modify, it has flare up, you will use the short course of steroid. With this concept, we can maintain the quality of life of the rheumatoid patient 10, 20, 30 years without the bone deformity. COVID-19 will be maybe the same. We have one question from the floor that is the clinic question concern in elderly use. Okay, please scroll down. And he said, my grandmother is 90 years and on the multiple conventional medication. Okay, this is the question about the precaution or what to aware in the elderly patient.
Yeah, so there is no reported concerns for elderly patients. It's completely safe for the elderly. As a matter of fact, the elderly that suffer with degeneration, the neurodegeneration, elderly that suffer with osteoporosis, osteopenia. These are type of inflammatory conditions that are very, very well supported by enzyme therapy. So most definitely, I definitely get the elderly population on enzyme therapy for that anti-inflammatory benefit.
Yes, I have reviewed this point of concern. The first thing, if you review the enzyme, compare protease blend to like a vascular directed enzyme like nattokinase. Nattokinase designed as a blood thinner. So if you have the comorbidity of the cardiovascular disease and already take the antiplatelet, whatever, aspirin, clopidogrel, or anticoagulant, this is the point to concern. The second thing, if the anticoagulant is the old-fashioned, like a warfarin, it has a lot of drug interaction. So you have to check the drug interaction. But for modern anticoagulant, very feels the report of drug interaction. Even warfarin itself, when you check the drug interaction to protease enzyme, it shows very low the drug interaction. But for the risk of the GI bleeding, in case of high dose protease plus the antiplatelet, this is the point I'm aware. Usually, for my common practice, due to I have experience with my patient who come with the upper GI bleeding, and when we do the gastrointestinal scope, nearly every case we found the H. pylori infection. And now it is recommendation if you have to take the long-term anticoagulant or antiplatelet, you need to check H. pylori. If you have H. pylori infection, even you take protease or not, or even not take any antiplatelet, you may have gastritis and the upper GI bleeding. So this is another concern. So I will summarize that you can use the protease enzyme quite safe, but you have to ask, you have to check, and it is better to check the status of H. pylori, not only for the enzyme use, but for the safety of other drug you use if your mother is 90 years old.
And for OA of the knee is very beneficial.
Yes. I think the protease is in the middle, not too much. If the people is like a common health problem, not specified to the atherosclerotic vascular disease, on that case, I think the blood thinner like a nattokinase is preferred. But out of that group for common people, protease enzyme is very okay for the long-term control inflammation. The key is what we need to control long-term inflammation. It must be low side effect compared to the prescribed drug, like the low-dose steroid. So enzyme will be the answer. And in the future, we may have some kind of phytonutrient that act directly to the NF-kappa B, but we have to wait for standardization. Someone said that, okay, protease enzyme have many, we use the enzyme 10, 20, 30 years. We want some kind of new drug. Some kind of new drug, new research will give you wow result. But when you see in the long term, it comes with wow side effect. We have the example of many cardiovascular drug, statin drug, that FDA already approved, but it's what stopped and reject the approval. We have many experience 10 years ago, from the 10-year past. I'm working as an internist in era of many drugs was removed from the market. Okay, if we have no more questions, let's give the stage back to the moderator to close the ceremony. And thank you all of the attendees and participants and all of speakers to share the valuable knowledge to Thai doctors and other countries' doctors to doing together to fight with the long COVID. Thank you.
Yes, indeed. We are very thankful for the session itself. And we'd like to once again thank both doctors for your time. And for Dr. Milton, especially, it's already past midnight. Thank you so much for staying up for all of us. And for Dr. Jirached, for you to take time off your busy schedule as well. Once again, thank you, everyone, to all the participants. Have a good weekend and stay safe. Thank you.
Thank you very
Bye.
much.
สวัสดีครับ
you